Institute for Tropical Medicine of the Department of Health. He is also the Assistant Treasurer, PSMID Board of Council. He is also the Vice Chairman, Section of Infectious Diseases at the Manila Doctors Hospital. He is a Clinical Associate Professor, Section of Infectious Diseases at the UPPGH. Ladies and gentlemen, help me welcome our speaker, Dr. Arthur Desi Roman.
Maraming salamat, Ayla, and I thank everyone for attending this session. Again, this is a presentation of the initial draft, the initial output of our technical working group, which I had for the updating of the clinical practice guidelines. This is not in any way the final version of the guidelines. This has to be presented to the consensus panel yet, but let this be a venue for soliciting your comments, suggestions, violent reactions, in case you have any about the following, the subsequent recommendations that I will be presenting. So again, this is the composition of the technical working group. The group is composed of representatives from the Philippine Society for Microbiology and Infectious Diseases. We also have representatives from the Philippine Academy of Family Physicians and from the Philippine Society of Nephrology and the Philippine College of Chest Physicians. Pardon me if I left out any person, because I was trying to finish the slides earlier. The steering committee is composed of the following. It's going to be headed by Dr. Solante. Also, we have representatives from PAFP, from PSN, PCCP, and even from DOH, represented by Dr. Gemma Arellano, who is the program manager for leptospirosis. And the identified members of the consensus panel, the ones who will vote for the recommendations, will be Dr. Chua, Dr. Mirna Mendoza, a leptospirosis expert herself. I'm still waiting a name from PAFP, PSN, here's the list, and from PCCP, Dr. Joel Santiagiel has agreed to be part of the consensus panel. Now, these guidelines, as much as possible, we are trying to be compliant with the manual for the creation of clinical practice guidelines by the Department of Health. And as such, we are going to follow the grade process. Pag sinabi niyong grade, it's grades of recommendation, assessment, development, and evaluation. So, merong grading of the strength of recommendation, tsaka yung quality of the evidence. And an example of those would be this one. Ito yung quality scale in terms of the evidence. So when you say high quality of evidence, usually this is evidence coming from well-conducted randomized controlled trials. Ibig sabihin, when the quality is high, it's unlikely that new evidence will come up that can change the conclusions or the recommendations. And for a very low quality of evidence, new evidence is necessary to come up with better conclusions. And usually, statements with or based from evidence na very low, these are expert, expert opinions. Now, in terms of the grading of the strengths of recommendation, you say it's strong when the desirable effects outweigh undesirable effects. Okay, so the way we phrase it is kapag strong yung recommendation ng statement, we recommend. So medyo strong yung pagkaka-word. Pag hindi masyadong mataas yung quality of evidence and medyo divided yung consensus panel in terms of their opinions, then the strength of recommendation would have to be weak or sometimes conditional, kung tawagin. So kapag sinabi niyong weak recommendation, the best available evidence was low quality, the uncertainty of the magnitude of benefits or risk is out there. So baka 50-50% towards benefit, 50% towards risk, and therefore the way you phrase the statement is you just say we suggest. Ibig sabihin, it's up to the clinician to follow the recommendations based on his or her decision making. So let's go through some of the statements. The first question that we will include in the guideline is the same as from the 2010 guidelines. It says here, what clinical manifestations should alert a health practitioner to suspect leptospirosis among patients presenting with acute fever? Remember that for the diagnosis of leptospirosis, a clinical diagnosis is very important because most of the available diagnostic tests are low in sensitivity, and sometimes mabagal yung turnaround time, and most of the time we are left with a clinical diagnosis to start or begin our management with our patients. So there is not much difference. We say here leptospirosis should be suspected in an individual with an acute febrile illness of at least 2 days duration and at least 2 of the following symptoms: myalgia, malaise, calf tenderness, conjunctival suffusions, chills, abdominal pain, nausea, vomiting, headache, jaundice, or oliguria, and the presence of an epidemiologic risk factor. And when you say epidemiologic risk factor, ito po yung mga factors that would place your patient at risk of getting leptospirosis, exposure dun sa urine ng infected animal. For example, residing in flooded areas, wading or swimming in flood and contaminated waters, with or without cuts in the skin, contact with animal fluids, including dead bodies ng animals or carcass, and ingestion of contaminated water. So this is a strong recommendation with the low quality of evidence. Most of these symptoms we based from the list of the most common symptoms that we were able to experience and were reported dun sa published studies coming from the Ondoy experience and the subsequent outbreaks of leptospirosis in Manila. Now, dati, meron na rin namang site of care decision guides dun sa previous guidelines sa 2010. But there's some clarification here. Meron tayong addition in terms of where we will admit our patient. Patients with suspected leptospirosis presenting with mild symptoms, the classification is the same, mild tsaka moderate to severe. Kasi in the literature, that's how they categorize yung severity ng leptospirosis. Very unclear pa rin on how you know. There's really a very thin line between moderate and severe, and so most of the time ay nilalump together yung moderate to severe leptospirosis. So patients with mild symptoms can be managed on an outpatient setting, and this include patients na merong stable vital signs, anicteric sclerae, no jaundice with good urine output, no evidence of meningismus or meningeal irritation, no dyspnea, no tachypnea, no hemoptysis, no bleeding, and the patient is not in any way septic or does not fulfill the criteria of sepsis. And of course, the patient should be able to take in the oral medications. This is a strong recommendation with low quality of evidence. This site of care decision making for cases of leptospirosis is actually based on the presence of identified risk factors for mortality in past studies and for the development not just of death but also for other leptospirosis-related conditions. For example, pulmonary hemorrhage and acute kidney injury. So, where do we admit patients with moderate to severe leptospirosis? First of all, ito yung mga pasyente na merong moderate to severe leptospirosis. It's almost the same. Those with unstable vital signs, those na naninilaw, those with abdominal pain, nausea, vomiting and diarrhea, anuric or oliguric, patients with bleeding, patients with meningeal signs and irritation, septic patients, those in shock, those with altered mental status, and those with respiratory symptoms. Kahit na takip niya pa lang yan, that patient will fall under moderate to severe leptospirosis already. Again, this is a strong recommendation, low quality of evidence. Now, patients with leptospirosis who are suspected to have pulmonary complications such as pulmonary hemorrhage or ARDS require special attention because these conditions have been consistently associated with increased mortality. If you are able to read most of the published literature from the Ondoy experience and all the other leptospirosis papers, parating lumalabas dyan na risk factor for mortality ang pulmonary hemorrhage and pulmonary complications. These patients present with dyspnea, tachypnea, chest x-ray, and even findings of localized or multi-lobar infiltrates or pleural effusion on chest x-ray, and the decision to admit a leptospirosis patient with pulmonary condition will depend on the level of hypoxemia, and this is in consultation with our pulmonary friends. So we categorize our patients to having mild, moderate, or severe hypoxemia. So you say a patient to have moderate hypoxemia if the PaO2 is more than 100. No, this is PF ratio. PaO2 to FiO2 ratio, less than 200, but more than 100, that's moderate. And then you say a patient has severe hypoxemia if the PF ratio is less than 100 with a PEEP. The patient is requiring a PEEP of more than 10 centimeters water. This is a strong recommendation with a low quality of evidence. So, for these patients, yung merong moderate to severe hypoxemia, saan natin sila dapat i-admit? Dapat sa ICU. Okay? Patients with moderate to severe hypoxemia need to be admitted to the intensive care unit for closer monitoring and or invasive ventilation. Patients with mild hypoxemia may be admitted in a step-down unit or a unit that is monitored closely, telemetry, ano pa ba yung other terms for a step-down unit? Or kung wala kayong step-down unit, sometimes in-order natin sa chart, di ba, admit to a room near the nurse's station for close monitoring. This is a strong recommendation with a low quality of evidence. Next, we talk about laboratory tests. The next question is, when should tests to confirm the diagnosis of leptospirosis be requested? The statement goes, given the generally low sensitivity and low turnaround times of diagnostic tests for leptospirosis, it is really not necessary for us to confirm the diagnosis or let alone wait for the result of this test before initiating any treatment. Clinical diagnosis, especially in the context of an epidemiologic risk factor and a high index of suspicion, are more important for us to initiate treatment. This is a strong recommendation with a very low quality of evidence. If definitive or confirmatory diagnosis is warranted, let's say you are not really convinced that this patient has leptospirosis, or for surveillance purposes, in suspected cases, for example, for public health reasons, you want to do surveillance, there are available diagnostic tests locally for leptospirosis. This is a strong recommendation with a very low quality of evidence. And let me just go through each of these available tests locally. What we have is the microscopic agglutination test, MAT, di ba? Ito yung pinaka-popular. This detects agglutinating antibodies against your live leptospires using dark field microscopy. And this is identified by the World Health Organization as the reference standard, second to culture, for example. But ang nire-recommend ng World Health Organization is the 21 0-bar MAT. This is the cornerstone of zero diagnosis of leptospirosis. However, there is an available genus-specific MAT using a non-pathogenic Leptospira pathoc 1 strain, and this is being performed by some centers. So when you are requesting for microscopic agglutination test, you have to ask dun sa laboratory na pagpapadala nyo kung ano ba talaga yung ginagawa. Is this, or are they going to do a 21 0-bar MAT, which is the reference standard, or an alternative with a low sensitivity and specificity, yung genus-specific MAT. Now, in terms of the interpretation, di ba, it comes out with a titer. The report is a titer. Kapag ang binigay sa inyo na titer ay isa lamang, then that is most probably a genus-specific MAT. Okay? And usually, ang cut-off na sinasabi natin for a single specimen to be positive is 1:1,600. But if you try to look into the literature, some would say it's 1:400, others would say it's 1:800. The exact cut-off for the titers for a positive MAT, we still have to present, and this would have to be voted upon by the consensus panel. Okay, so we have to wait for this. Yung paired specimen, this is, sabi nila, a better test for us to say that your patient really has a definitive leptospirosis is when your patient seroconverted from a low titer, tapos after 2 to 4 weeks you repeated your math, mas tumaas yung titers, nag-increase by fold, or from negative nag-positive, that's seroconversion, then that is more or less diagnostic of leptospirosis. Now, the new guidelines will comment on the use of rapid leptospiral diagnostic kits, yung mga lateral flow assay, the immunochromatographic tests or ICTs. These are useful rapid tests in the early diagnosis of leptospirosis, especially at 2 weeks of the disease among patients with compatible signs and symptoms. There is an increasing number of tertiary healthcare facilities that are actually offering this rapid test already. So, the recommendation for the use of this rapid leptospiral diagnostic test, yung mga ICTs, strong recommendation with a high quality of evidence, and this is the summary of findings table for this particular recommendation. Because the pooled sensitivity is at around 84%, the specificity is a bit low, 74%, but in terms of the quality assessment of the included studies, medyo maganda kasi siya. The risk of bias is really low. Now, meron ding studies on ELISA. I'm not sure if some institutions here in the Philippines is doing IgM ELISA for leptospirosis. These are simple tests with also acceptable sensitivities that is quite variable depending on how you do your ELISA. This is a strong recommendation with a moderate quality of evidence, and this is the summary of findings table. Sensitivity around 85%, specificity 84%. Quality assessment ng mga included studies, hindi rin ganun kasama. Okay, so medyo high quality evidence then. That's why we've decided to include statements on the use of IgM ELISA. Now, we know that some of you might have a hard time trying to determine which test to request, depende dun sa timing, kung kailan nag-present yung pasyente in terms of disease duration. So we will include in the guidelines a table something similar to this one, appropriate timing of specimen collection for specific leptospiral tests. So hopefully, this will help the users identify kung ano yung isisend na specimen and kung para saang test yung ire-request nila when a patient presents within the first 7 days of illness, or if a patient presents on the second week of the illness, or when the patient presents past 2 weeks of the illness. For example, if your patient presents within the first 7 days, then you might want to do your CSF for culture or dark field microscopy. You can also actually request for dialysate, for leptospiral culture, blood cultures. Remember, yung blood culture natin, this is different from our routine blood culture. Ha? So you have to specify when you want to isolate your leptospirals, kailangan ilagay nyo sa request leptospiral blood culture because they will use a different type of culture media. Now, this is also something new dun sa guidelines. What non-leptospiral test should be requested? Meron ganitong question in the 2010 guidelines, but the previous guideline did not stratify the patient as to those with mild symptoms and those with moderate to severe symptoms. So what the nephrology group decided or recommended is we divide this list according to the risk of the patient. For example, for mild patients, ito yung must-do natin. CBC, urinalysis, BUN and CREA, and liver function test. But for patients with moderate to severe leptospirosis, then you have to add the following test as needed dun sa routine test that we have to do for patients with mild leptospirosis. So you have their serum sodium and potassium, the bilirubins, bleeding parameters, TPAG, chest X-ray, 12-lead ECG. For those with pulmonary symptoms, ABG, CPK with fractionated CPK-MM determination. Now, in terms of the treatment, The statement goes, all patients with suspected leptospirosis should be started on antimicrobial therapy regardless of the phase of the disease duration of symptoms, and this is to shorten the duration of illness. This is a strong recommendation with a low quality of evidence. Treatment with effective antibiotics should be initiated as soon as the diagnosis of leptospirosis is suspected. Antibiotic administration should not be delayed regardless of the need for renal replacement therapy. Now, yung second statement, kung mapapansin nyo, there's an underline dun sa antibiotic administration should not be delayed regardless of the need for renal replacement therapy because the nephrology group has identified a certain problem. Ang ginagawa daw ng ibang clinicians, pinapabigay yung antibiotics after the dialysis. Kasi nga, kapag nag-dialyze, ang concern nila, baka kailangang magbigay uli ng another dose of the antibiotics, and they don't want that to happen. Ang sinasabi kasi, as soon as there's a diagnosis of leptospirosis, start your antibiotics right away. Redose if you must, but start it right away. So, the basis for initiating antibiotics for leptospirosis is mostly based on this particular systematic review. This systematic review included all patients with infected with leptospirosis. The intervention that they included are all antibiotics expressly given for treatment of leptospirosis versus placebo versus no intervention or another antibiotic. And some of the primary outcomes that they tried to look at are the following: overall mortality, death from leptospirosis, hospitalization, the need for mechanical ventilation, and even dialysis requirement. This is a systematic review, and if you are going to look at the quality of the studies involved, most of them, medyo hindi natin alam yung quality assessment in terms of randomization, allocation concealment, kasi medyo marami dyan yung kulay yellow, may question mark. Ibig sabihin, that has not been expressed, no, that has not been clearly described in the methodology. So, looking at this mostly, or at the most, baka mamaya, moderate quality of evidence lang yung ma-generate natin coming from this particular systematic review. So, what were the results? Ang konti lang kasi ng mga studies na na-include. There's only 4 studies that looked into death, and the number of participants for that particular outcome only included 403 patients. Alright? Tapos, the effect size is 1.16, but really this is not significant because the confidence interval is 0.23 to 5.95. There was only 1 study that looked into days of hospitalization, 2 studies that looked into clinical illness and dialysis employment. Yung 2 studies only involved 71 participants for those na merong outcome na days of clinical illness. Medyo mas marami dun sa dose, marami dun sa studies, 332 that looked into dialysis employment, initiation of dialysis. Okay? So, kung mapapansin nyo, in terms of the magnitude of effect, isa lang dyan talaga yung merong beneficial effect na significant. It's decrease in the days of clinical illness by around 4.04, and the effect size is from -8 to 0.58. In terms of which antibiotics to use, cephalosporins versus penicillin, 2 studies, really because of the small number of patients included in the study, wala talagang nakitang beneficial effect. If you compare doxycycline, which is an antibiotic recommendation also for the treatment of penicillin allergic patients and low-risk patients sa outpatient, compared with penicillin, 1 study, tapos halos wala ring ma-generate na significant conclusion. Azithromycin versus doxycycline, and even your cephalosporin versus doxycycline, wala rin. So the reviewer's conclusion is there's insufficient evidence on the use of antibiotics in preventing death from leptospirosis. However, the beneficial effects on the use of antibiotics on several clinically relevant outcomes have been deemed important. And for us, the technical working group, yung decrease in the duration of illness by about 2 to 4 days, we deemed that as important, not only in terms of, inisip kasi namin kung ang pasyente ba ay makakatipid ng 4 na araw from staying in the hospital, is that significant? Diba? I think in the setting of the Philippines, important siya. Cost, the risk for getting healthcare-associated infections, diba? Relatively severe and possibly late leptospirosis patients may have increased dialysis when penicillin is used rather than placebo, but then again, this is not significantly different. Hence, antibiotic treatment is recommended. So, in terms of the antibiotic recommendations, ano ba yung i-recommend natin? It's going to be the same as the 2010 guidelines. So, for mild leptospirosis, we give doxycycline as first line, alternative amoxicillin, azithromycin. For moderate to severe leptospirosis for adult patients, when you have to give it intravenously, you give your penicillin and ceftriaxone, and then alternative regimens would be your ampicillin, azithromycin, and cefotaxime. So, we're done with treatment. I will now give you some overview about the use of steroids. Let me just present this systematic review involving patients diagnosed with severe leptospirosis with pulmonary involvement, and the intervention here is the use of whatever steroids. Okay? And the outcome they looked at is survival or mortality. And this is the list of those studies. There's one in 2005 and another one in 2011. Medyo maliit yung sample size kung mapapansin nyo yung nung isa. 8 and another one back in 2011. There's 62 patients only. And then there's another one in India back in 2006 and in 2010, wherein they divided the groups into 3, 23, 22, and 23 participants. This particular study did not report any mortality benefit in outcomes that we have identified. But in general, the conclusion in this particular systematic review is no recommendations pa rin can currently be made based on clinical evidence, based on the available evidence regarding the use of corticosteroids in severe leptospirosis. Now, you might have heard about the use of cyclophosphamide in addition to steroids when you are dealing with moderate to severe leptospirosis patients. Dito nagsimula yon, yung practice na yon. The population here involved 65 patients with confirmed leptospirosis with severe pulmonary involvement. So the intervention was the standard treatment, antibiotics, hydration, plus cyclophosphamide, and they compared it with no cyclophosphamide, and they tried to look at the survival of these types of patients. So, ang naging result ng study na to was that more patients who received the cyclophosphamide treatment survived. So the survival rate is around 66.7% sa mga patients who received the cyclophosphamide treatment versus 9.4%. But again, this is not a high quality evidence. The author's conclusion here is cyclophosphamide is useful in the treatment of pulmonary hemorrhage due to leptospirosis. Leukopenia and alopecia are the main side effects noted due to cyclophosphamide. But of course, you have to consider the sample size of this particular study. Now, there's another study that involved patients with confirmed leptospirosis with mild pulmonary hemorrhage admitted in a tertiary hospital. Yung group 1, in terms of the intervention, they gave penicillin plus steroids plus ventilation and cyclophosphamide, and yung group 2, yung traditional without the cyclophosphamide therapy, but still with the steroids, and they looked at the survival, and they were able to find out that dun sa mga patients who received steroids plus cyclophosphamide, more patients survived. That's 61.4% compared to 16.6% dun sa patients who received the steroids but not the cyclophosphamide. So the author's conclusion here is plasma exchange together with cyclophosphamide may be useful to treat mild cases of pulmonary alveolar hemorrhage. Mild kasi ito yung mga types of patients that they were able to include in the study. So, in terms of the experience of NKTI, I'm not sure if we do have representatives or doctors from NKTI here. They tried to write down, publish their experience on the use of methylprednisolone and cyclophosphamide on the survival of patients with leptospirosis, renal failure, and pulmonary hemorrhage. So in this particular study published in 2014 involving patients diagnosed with severe leptospirosis and a requirement for dialysis admitted in their institution from 2009 to 2013, the intervention, actually parang single arm to, is hydrocortisone versus methylprednisolone. They compared hydrocortisone versus methylprednisolone cyclophosphamide therapy. The primary endpoint that they look at is overall survival rate. If you try to take a look, there were more patients, there were more patients who survived na nakatanggap ng methylprednisolone plus cyclophosphamide. The survival rate dun sa methylprednisolone plus cyclophosphamide is at 88% compared to 74% to those patients who receive hydrocortisone alone. Tapos mas mababa din yung death due to pulmonary hemorrhage among those who receive methylprednisolone plus cyclophosphamide. So the author's conclusion, the 3-day course of methylprednisolone plus single dose of IV cyclophosphamide significantly improved survival among patients with leptospirosis, renal failure, and pulmonary hemorrhage. But try to take a look at this subset of patients. Very specific, di ba? Leptospirosis na, tapos may renal failure, tapos meron pang pulmonary hemorrhage. And there's significant improvement in terms of level of PTT in patients treated with the prednisolone plus cyclophosphamide therapy. I was not able to highlight this in the previous table. Now, there's another publication, outcome of adults with leptospirosis and renal failure treated with pulse immunosuppression. Ito yung sinasabi ko na single arm. They tried to describe their experience with methylprednisolone plus cyclophosphamide, and their mortality rate is around 25% lang. So the conclusion of this particular, take note, those are patients na merong, tignan niyo yung involved patients dyan. These are patients with leptospirosis and renal failure. So ang na-identify nila na mortality rate is just 25%. And the conclusion is 25% mortality rate among patients diagnosed with leptospirosis with renal failure treated with pulse immunosuppression, with majority dying because of pulmonary hemorrhage. Thrombocytopenia, prolonged pro time, and infiltrates on chest X-ray are the predictors of mortality. Transfusion of FFP and platelet concentrate was more common in this population group. So, steroids have really been reported to reduce or delay the need for ventilatory support, improve PTT or mortality among patients with leptospirosis at high risk of pulmonary hemorrhage. So what we're thinking is we come up with a list of patients that are eligible for receiving corticosteroid therapy. So ito yung mga pasyente na yon. Patients with suspected or confirmed leptospirosis with or at a high risk of pulmonary hemorrhage and any of the following: acute kidney injury plus platelet count of less than 100, a MAP of less than 65 millimeters mercury, prolonged bleeding time, and the need for inotropes. Conditional recommendation, low quality of evidence. And in case you decide to use your corticosteroids for this subset of patients, ito yung mga recommendations na pwede nating ibigay. So if there is a decision to use steroids to such patients, it should be initiated as soon as the first signs and symptoms of pulmonary involvement is identified. And not just pulmonary involvement, kasi meron din tayong renal indications, di ba, for starting our steroid initiation. This is conditional recommendation with a low quality of evidence, and these are the regimens that you might want to use. Methylprednisolone, 500 milligrams IV after hemodialysis once a day for 3 days. And then after the third methylprednisolone dose, or after any episode of hemoptysis, give a dose of your cyclophosphamide, 1 gram IV as a single dose. Or methylprednisolone at a dose of 1 gram IV per day for 3 days, with the first dose given as a bolus within the first 12 hours of onset of respiratory involvement, followed by oral prednisolone 1 milligram per kilogram per day for the next 7 days. Kasi merong studies na ganito yung ginamit nilang regimen. Again, this is conditional recommendation with low quality of evidence. Now, we are intending to write a statement on the dialysability of methylprednisolone in contrast to your hydrocortisone. So we have to watch out for that. Kasi ang concern ng mga nephrologist ay nadadialyze ang methylprednisolone, and so when there is a need for you to start giving your corticosteroid, sometimes i-delay uli nila yan until after dialysis, versus just giving it right away and then just giving another dose after the dialysis. So, this is another output, another algorithm from our nephrology friends, and this is in terms of the management of oliguria. Sorry, medyo ang liit nung algorithm, but let me just go through this. So for patients presenting with oliguria, what you need to do is you need to assess your fluid status of the patient, clinical fluid status, whether the patient is hypovolemic over here, euvolemic, or hypervolemic. So dun muna tayo sa pinakamadali. Yung hypervolemic patients, you have to refer them right away. Remember, ang entry point natin ay oliguria, hindi na umiihi ang pasyente, tapos fluid overloaded na sila. So you need to refer them to your nephrologist right away, okay? And especially if their creatinine is already elevated more than 3 milligrams per deciliter, gusto nila ma-dialyze agad yung pasyente. And this is also true for patients na euvolemic, normal volume status. You have to refer them right away, normal volume status pero hindi umiihi, tapos mataas na yung creatinine more than 3 mg per dl, dialyze agad yan. Okay. Now, for those patient na hypervolemic, tapos hindi pa ganon kataas yung creatinine, well, this is an expert opinion. Sabi nila there's some room for diuresis. Okay? To give your diuretics. For example, it says here, we can give an initial dose of IV furosemide at a dose of 1 milligram per kilogram. You need to assess the urine output after the initial dose after 1 hour. So look at the timing. Hindi tayo masyado magtatagal. 1 hour lang, titignan agad natin kung nag-respond yung pasyente natin in terms of urine output. So, if the patient is still oliguric, then you give a double dose. Let's say you give an initial dose of 60 milligrams of furosemide, then you give another dose of 120 milligrams, and then you observe for another hour. Or you can have your creatinine repeated. If there is an increasing trend of creatinine, dun din ang ending natin. So, dialysis din yung pasyente. So, we're talking here 4 to 6 hours. Ibig sabihin, by the 6th hour, nagda-dialyze na yung mga pasyente na kailangan nating i-dialyze. Now, kung halimbawa nag-respond yung patient, yung hypervolemic patient, with the first dose of our IV furosemide, kasi nagkaroon sila ng urine output of 0.5 ml per kilogram per day, then we can continue our hydration and diuresis. So, let's go to the euvolemic patients na hindi ganun kataas yung creatinine less than 3 milligrams per deciliter. What it says here in the algorithm is observe carefully, and you can continue giving your hydration whether orally or IV at a dose of 25 to 30 milligrams per kilogram per day. Assess your urine output, or you repeat your creatinine after 3 hours. So, 3 hours yung timing naman dito. If the patient will urinate, if there will be adequate urine output, then you can continue observing. But if you repeat your creatinine or there is no improvement in the urine output after around 3 hours, then ang ending uli niyan ay dialysis. Again, kung mapapansin niyo, medyo mabilis yung decision for early dialysis. For hypovolemic patients, you have to consider if your patient is hemodynamically stable or not. You have to check on the mean arterial pressure. So if the MAP is less than 65 millimeters mercury, okay, ibig sabihin, hypotensive ang pasyente. Of course, you need to replace your fluid. Fast drip by giving your balance solution or NSS at a dose of 20 milligrams per kilogram or 500 ml over 15 minutes. Look at the timing, 15 minutes, and then check if the BP will improve. If yes, you can start your norepinephrine at this dose and then assess the hydration status kung hypovolemic pa rin siya or enough na yung initial bolus na binigay nyo ng fluid. If not, then you can still continue giving more fluids, 250 ml to 500 ml. But take note that this recommendation, hindi nyo hinayaan na mababa yung mean arterial pressure ng pasyente. You already started your norepinephrine drip while continuing your IV hydration. And then, so that's ilan ba? 15 minutes dun sa unang assessment, and then probably after another 15 minutes, you do your reassessment of the urine output. So that's 30 minutes to 45 minutes. If the patient is still oliguric by that time, ang sabi dito, refer to a nephrologist because really, you should think of early dialysis. Dun sa kabilang arm, kung hindi hypotensive yung pasyente, you give your balance solution or NSS at a dose of 20 ml per kilogram also or 500 ml over 1 hour. Sa kabila kasi 15 minutes kapag hypotensive yung pasyente. Pero kapag hindi naman hypotensive, 1 hour and then assess your hydration status. If euvolemic na siya, then you assess your urine output. If it's more than 0.5 ml per kilogram per hour, then you can just continue giving your hydration sa inyong pasyente, whether oral or IV. Of course, if there's no response, again, ang ending niyan is nephro-referral for early initiation of dialysis. Now, what is the recommended initial fluid resuscitation for leptospirosis? The recommended initial fluid resuscitation for leptospirosis is balanced crystalloid. This recommendation is actually based on sepsis studies, but the concern here of the nephrologist is that yung balanced crystalloids might have potassium, and so if potassium is in the high normal value or the patient has hyperkalemia, then you still have to use your isotonic saline. This is recommended. Hydroxyethyl starch should not be given because it is associated with increased risk of acute kidney injury and need for renal replacement therapy and even mortality. Strong recommendation. This is downgraded to moderate quality of evidence. How should fluid resuscitation be done? The recommended initial fluid resuscitation based on the algorithm that I showed you is 20 ml per kilogram per hour or 500 ml of balanced crystalloid within 15 to 30 minutes. This is for patients with MAP, less than 65 millimeters mercury. For patients with leptospirosis who are prone to ARDS due to downregulation of the sodium transport via epithelial sodium channel, NAK-ATPase, as well as increase in aquaporin, and so kailangan maingat tayo sa paggamit natin ng balanced crystalloids. Again, potassium concerns. This is strong recommendation with a moderate quality of evidence. And finally, the last issue that I would like to present to you guys would be the management of pulmonary complications in leptospirosis. So sabi ko nga sa inyo, when your patient suspected to have leptospirosis, moderate to severe, presenting with respiratory symptoms, cough, dyspnea, hypoxemia, tachypnea of more than 22 or even hemoptysis, kapag wala, then you can continue observing your patient. But if there is the presence of any of these symptoms, you have to initiate your steroids right away. Of course, you have to start your antibiotics. But the decision kung saan nyo a-admitin yung pasyente, whether ICU or step-down unit, ay magdedepende sa level of hypoxemia. Right? Do you remember my first, yung mga fifth slide ko siguro? So for patients with mild hypoxemia, PF ratio of more than 200, these patients are for close monitoring, but still, you have to give your methylprednisolone. Alright? And antibiotics, and you can consider non-invasive ventilation for these patients. For patients with moderate to severe, again, kahit na magkahiwalay yung moderate tsaka sa severe in terms of hypoxemia, these patients, leptospirosis patients, pareho ang management. Admit them into the ICU, initiate invasive ventilation, antibiotic initiation, methylprednisolone therapy, and always check the hemodynamics of your patient. We do have some statements on the use of ECMO, but again, ECMO is not readily available, and I would have to consult with the sepsis group about how they will phrase their recommendations of ECMO for septic patients. But as far as the use of ECMO for leptospirosis patients, the evidence is very limited. So that's the end of it. Thank you very much for your time. That's 47 minutes and 53 seconds. I think if you do have concerns, I can take them down, take note of them. If you have comments or concerns, I can also take them down. Thank you very much.
Thank you very much, Dr. Roman. So, in the interest of time, we will not entertain any more questions, but I would like to give a summary of what Dr. Roman has lectured today. That, first of all, clinical diagnosis is important. Diagnostics, it's good if you have them, but there's long turnaround time, and mild symptoms of leptospirosis, you could treat them in the outpatient setting. And remember that those patients with hypoxemia, you need to admit them to the ICU. Antibiotic treatment should not be delayed, regardless of the presence or absence of your diagnostic exams. And you need also to remember that regardless there's no dialysis machine there or not, you need to do your antibiotic treatment right away, okay? There are promising studies on the use of your cyclophosphomides and steroids, but in severe leptospirosis, you need to think about it because they may actually decrease your mortality and morbidity. And again, decision for early dialysis may actually be life-saving. So if you have any questions for Dr. Roman, you may approach him. He's a very kind and very accommodating person. So I would like to call on my co-chair to distribute the certificate of appreciation for Dr. Roman. Let's all give him a warm applause. Picture tayo sa